Good afternoon, everyone. I'm Christine Forstner, the LPCA HCCN Director, and together with Tonya Canali, the Clinical Quality Director at LPCA, we welcome you to the Lunch and Learn session titled Advances in Guidelines in Evidence-Based Hypertension Management, Tailored to Your Clinic. This webinar is being sponsored by LPCA and the Louisiana Department of Health and Hospitals, part of the Chronic Care Disease Grant 1305 with DHH. We are pleased to have cardiologist Dr. Keith Ferdinand, professor at the Tulane University School of Medicine. He will discuss how health centers can promote clinical innovation, team-based care, and self-monitoring of blood pressure using current hypertension guidelines. This is a housekeeping item. In order to stay within our time frame, we will hold questions until the last 15 minutes of the webinar. All participants will be in listen-only mode. Please type in your questions throughout the broadcast in the question box located on the webinar screen. If we run out of time, you can email your question to us and we will follow up with you after the webinar. Our contact information will be displayed at the end. Thank you for participating in these series. Dr. Ferdinand, you can begin.
Thank you very much. I'm going to move along quite briskly. I would first like to thank all of you for taking time in the middle of a very busy day to participate in this webinar. The title is Advances in Guidelines and Evidence-Based Hypertension Management Tailored to Your Clinic. You see my name there. The letters behind my name is a fellow of the American College of Cardiology, American Heart Association, National Lipid Association, and the American Society of Hypertension. Those are societies in which I hold the fellowship. I'm now a professor at Tulane. These are my disclosures. I'm not mentioning any particular brand name, so there will be no conflicts. So our goals is first to increase your awareness of hypertension and its impact. Second bullet, to identify and incorporate best practice guidelines for clinical management of hypertension at federally qualified health clinics. And finally, to improve clinical and self-management of hypertension in Louisiana at your clinic. We're first going to overview some of the best practices, JNC8 recommendations, a new trial which was only recently published, which is actually landmark and may change guidelines going forward, known as SPRINT. We'll talk about that in detail. And I'm going to end with some really practical, real-world pearls on treating the whole patient, discussing not only medication but lifestyle changes and team-based care. So let's first look at a guideline that was published in 2014, early 2015. It's abbreviated as JNC8. It actually is not a true JNC8 since the National Heart, Lung, and Blood Institute did not give its blessings. This was the panel members originally appointed to that committee who decided to publish the paper in JAMA. And the title of the paper is the 2014 Evidence-Based Guideline for the Management of High Blood Pressure. So we'll use the shorthand of JNC8, but it is not an official National Heart, Lung, and Blood Institute document. In fact, here's this slide. I pasted in language directly from the paper itself published in JAMA in 2014 that the report is not NHLBI sanctioned and does not reflect the views of NHLBI. The reason that's important because there is some controversy in that report and we'll discuss that going forward. There are various recommendations in that report to which you should be aware. Some of them are related to treatment goals, and specifically for persons who are over the age of 60, the goal of blood pressure lowering was changed from 140 to 150, and I'll show you those recommendations in a second. As it relates to drug therapy, they made recommendations to use at least 4 specific classes of medicines: ACE, ARBs, calcium channel blockers, and diuretics. And they made a specific recommendation as it relates to treatment of African Americans or black patients, and that will be demonstrated in a slide shortly. First, let's look at the controversial goal for persons who are 60 years and above. Based on a review of the evidence, they felt that there was not evidence to prove getting the blood pressure less than 150 would give benefits in terms of cardiovascular morbidity and mortality. So they suggested that for persons who were 60 and above, that the new goal of treatment be 150 or above. And treating to less than 150 would be the goal for systolic blood pressure, maintaining the less than 90 for diastolic blood pressure. The middle bullet points to the fact that they did make a recommendation specifically related to race, ethnicity. For non-black patients, the initial pharmacologic agent could be a thiazide type diuretic such as hydrochlorothiazide, an ACE or an ARB, an ACE such as lisinopril, an ARB such as losartan, or a calcium channel blocker such as amlodipine or verapamil, and these could be used, of course, in combination. Specifically because there is less robust data showing that blood pressure can be effectively lowered with an ACE or an ARB in black patients, the JNCA committee suggested that the thiazide type diuretic or the calcium channel blocker alone or in combination be the first step in black patients. So two salient points in their recommendations. One was the new goal for persons who are 60 years and older of less than 150 versus less than 140, and specifically removing ACE and ARBs as an initial first step in black patients. For the general population, however, who are less than 60 years of age, they stayed with the 140 for initiation of therapy and the treatment goal of less than 140 over 90. This specifically points to the black patients in the triangle. You see the three main classes of medicines that are used: diuretics, calcium antagonists, ACE inhibitors, or angiotensin receptor blockers. And on the left-hand side of the triangle, you see for the black population, the JNCA committee recommended diuretics or calcium channel blockers. They went so far also to suggest that beta blockers, which have been used for a long time in the treatment of hypertension, should only be included in the regimen if there is a compelling indication for a beta blocker. Compelling indication means that there's something other than the blood pressure itself that indicates that the beta blocker is needed, such as a person who may have post-myocardial infarction status, clearly at least for 1 year needs to be on a beta blocker, or a patient with reduced ejection fraction heart failure needs to be on a beta blocker, often combined with an ACE inhibitor or diuretic. It should note at the top of the triangle, lifestyle modification, especially diet and exercise, is really the first step before pharmacologic treatment, and we'll talk about lifestyle management towards the end of this discussion. The committee recommended certain antihypertensive medicines and the doses based on the evidence. For ACE inhibitors, they specifically call out captopril, enalapril, and lisinopril, although lisinopril is perhaps the most commonly used at this point. For the angiotensin receptor blockers, they're listed there. Again, losartan is probably the most commonly used, but there are good data also with valsartan and irbesartan. For beta blockers, atenolol is listed along with metoprolol. It should be noted in some hypertension specialist circles, metoprolol succinate, the long-acting formulation, is considered to be a better beta blocker for the 24-hour control of blood pressure than atenolol, which tends to be short-acting. For the calcium blockers, towards the bottom of the chart, they list amlodipine, extended-release diltiazem, and another amlodipine-like drug known as nitrendipine, which is usually not available. For thiazide-type diuretics, they mention certain thiazides. I should note that chlorothalidone, the second thiazide-type diuretic, is listed here. There's actually more outcome data with chlorothalidone than with hydrochlorothiazide, although hydrochlorothiazide is most commonly used. Chlorothalidone on a milligram-to-milligram basis is actually more potent and may be more effective than hydrochlorothiazide. Amlodipine is very long-acting, has a smooth curve, and works across all populations regardless of race, ethnicity, or age, and is also used extensively for the treatment of hypertension. One of the problems with ACE inhibitors that I think you should be aware of is angioedema. It's an idiosyncratic reaction with the inhibition of the angiotensin-converting enzyme causing an upregulation of bradykinin. Bradykinin results in vasodilatation and vascular permeability, such that you get swelling of the lips, the tongue, the eyes, and even the pharynx. And in worse cases, the patients may need to be hospitalized. The quirky thing about angioedema is that its onset may occur shortly after or even years after long-term use with ACE inhibitors. So informing the patients if they have a very fluid reaction to a medication, they should be aware of the potential for angioedema. It's more common in black patients, approximately 1 out of 1,000, than it is in white patients, approximately 1 out of 3,000, and we're not sure why it is more common in blacks. I had mentioned to you a landmark trial which I thought would have a great impact on how we treated hypertension going forward. The name of the trial is the SPRINT trial, Systolic Blood Pressure Intervention Trial. Let's look at SPRINT. This was a National Institute of Health sponsored trial, and the research question was the following: including persons who are over the age of 60, and remember the controversy with the JNCA committee, which suggested that less than 150 would be the new goal. It is now suggested, based on the SPRINT, that there is data that treating to an intensive goal of a systolic blood pressure less than 120 may give a benefit versus the standard blood pressure goal of less than 140, and this includes persons who are 60 years of age and older. Note that this was a very large, broad trial throughout the United States. 102 SPRINT clinical centers, over 9,000 patients. And typical of many NHLBI and NIH-sponsored trials, they specifically made point to enroll blacks and other minorities, who made up 38% of the cohort. To answer the question whether or not there's benefit in persons who are over the age of 60 in being more robust in the treatment of blood pressure than suggested by the JNCA committee, they also enrolled people who are over the age of 75, and 20% of the patients had prior cardiovascular disease. On September 11th, 2015, there was a news release from the National Heart, Lung, and Blood Institute saying that SPRINT would stop early versus its scheduled stop at the end of this year. The early stoppage was due to an improvement in total mortality and cardiovascular benefit treating blood pressure intensively. For more information on the SPRINT trial, there's publicly available resources, www.sprinttrial.org. It's listed at the bottom of the slide. I'm still here. I'm waiting to pause to go to the next slide. Perhaps the host can go to the next slide. I'm having some difficulty. Okay, here it is. This is a depiction of the various SPRINT sites. And one of the things you'll note is that Puerto Rico is included. Although it's not one of the 50 of the United States, Puerto Ricans are United States citizens. They are Americans and were included in the SPRINT cohort. There were 2 sites here in Louisiana, and you note there were sites throughout the Southeast, which are areas at high risk for hypertension and cardiovascular disease, including blacks. So let's look more detail at the SPRINT trial. It included persons who were 50 years and above. They had to enter with a systolic blood pressure that was 130 to 180, either treated or untreated. And these patients, being middle-aged with hypertension, also had to have an additional cardiovascular risk. So the point was to include high-risk patients. They needed to have clinical or subclinical cardiovascular disease other than for stroke. They could have chronic kidney disease with a calculated glomerular filtration rate of 20 to less than 60. a calculated Framingham risk score of greater than or equal to 15%, or the additional risk along with hypertension could be age of 75 years or above. So the SPRINT was testing this hypothesis in a high-risk population. It should be noted the patients that were not included in SPRINT included patients with previous stroke, diabetes, polycystic disease of the kidney, congestive heart failure, high levels of proteinuria, severe levels of chronic kidney disease with GFRs less than 20, and patients who would not be able to adhere to the robust needs of the SPRINT protocol. Here are the results. Note standard treatment actually was well done, achieving blood pressures of approximately 138. Not bad in a high-risk population. But intensive treatment clearly separated, getting blood pressures closer to 120. And now the question was whether getting the blood pressures to this intensive treatment level would give benefit. The answer is yes. This is called a Kaplan-Meier survival curve. The primary outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from cardiovascular causes. At the top of the box of the diagram, you see intensive treatment at about a year or so separates from standard treatment, having less of these cardiovascular events or death. The hazard ratio was 0.75, meaning a 25% reduction in the composite primary outcome. The confidence intervals, or CI, are 0.64 to 0.89. A confidence interval less than 1 means that you can be statistically certain that this was a benefit with intensive treatment. One of the reasons SPRINT was stopped early was because of death. Mortality or death is an outcome which trumps almost all other outcomes in any clinical trial of outcomes. You can note again the orange, the intensive treatment, this time at approximately 2 years starts to separate from the standard treatment. The hazard ratio is 0.73, meaning that there was a 27% reduction in death from any cause at all in patients who were treated more intensively. Also note that the confidence interval 0.60 to 0.90 again is less than 1, confirming that SPRINT gives a benefit in the reduction of death of any cause by treating patients more intensively. One of the benefits of the SPRINT trial, although it was not a medication versus another medication type of study, is that it did give us some information on what cocktail of medications can effectively lower blood pressure in this high-risk population of persons who are 50 years and older with additional cardiovascular disease or kidney disease. Their diuretic is chlorothalidone, anywhere from 12.5 to 25 milligrams. This is actually the thiazide type diuretic that was used in the SHEP, systolic hypertension in the elderly program, that showed a benefit in treating isolated systolic blood pressure in persons 60 and older. It was also the diuretic used in ALLHAT, the largest antihypertensive trial ever. Chlorothalidone, unfortunately, is perhaps underutilized in usual clinical practice, but especially in high-risk and difficult-to-treat patients, there's outcome evidence that chlorothalidone is an effective first-step thiazide-type diuretic, more potent and longer-acting than hydrochlorothiazide. Their calcium channel blocker of choice was amlodipine. Amlodipine has the benefit of also having a very long action, well tolerated in patients regardless of sodium intake, race, ethnicity, or age. ACE inhibitors were considered to be perhaps less effective in blacks in terms of both treating blood pressure and preventing cardiovascular disease. So in African Americans, the first step tended to be a thiazide-type diuretic or calcium channel blocker. This reflects to a large extent what we saw when we looked at the JNC8 recommendations on initial therapy in black patients. Patients who have more severe levels of kidney disease may not benefit from a thiazide type diuretic because of the ineffectiveness in patients who have glomerular filtration rates of less than 30 ml per minute per 1.7 meters squared. In that particular case, a loop diuretic, because it works at the loop of Henle in the nephron, such as furosemide, may be needed. They also discouraged the investigators from using an ACE, an ARB, or a renin inhibitor together. This increases the side effects of the RAS blocking agents and has not been shown to improve outcomes. Similar to what we saw when we reviewed the JNC8 recommendations, beta blockers were considered less effective in preventing cardiovascular disease as a primary treatment for hypertension. But of course, if the patient also had coronary disease or post-myocardial infarction status, beta blockers would be needed. A drug which has been commonly used in the past, known as minoxidil, is a potent vasodilator. However, they suggested that if minoxidil is used, adequate diuretic is necessary since patients often have a retention of fluid with vasodilators. An alpha agonist known as guanfacine or a clonidine skin patch was recommended versus oral clonidine. Oral clonidine, unfortunately, has a very short half-life, and along with some of the side effects such as drowsiness, nasal stuffiness, and erectile dysfunction, patients often abruptly discontinue oral clonidine and will have a rebound effect since the blood pressure has only been controlled for a short period of time throughout the day. Guanfacine is also an older medicine, similar to clonidine, but has a longer half-life and can be effectively used in the very difficult patients. And of course, the clonidine patch, which leaches into the skin, lasts approximately a week, gives a longer half-life, and avoids the rebound seen with the oral clonidine. So we've talked about the guidelines, and we've talked about some of the medications used in the SPRINT study. SPRINT taught us that there are now data confirming that lower may be better in middle-aged and older persons to decrease the blood pressure clearly less than 140, not the 150 recommended by the JNC8 panel, and perhaps as low as 120. This has not been entered into guidelines as we speak, but there are other guidelines which will perhaps consider this SPRINT data in making their recommendations in the future. Let's switch now from directly talking about drug treatment and clinical outcomes trials to some practical approaches to treating the whole patient, because that in fact is how we have to see patients as not just blood pressure, but a combination of risk and a combination of adverse lifestyles that need to be approached. The New York City Health and Hospitals Corporation have their own adult hypertension clinical practice guidelines, and this quote comes directly from there, suggesting that the most effective therapy prescribed by the most careful clinician controls patients only if they're motivated. We need to talk to our patients and educate our patients about the effects of hypertension and why they need to change their lifestyle and perhaps take multiple medications to control this deadly condition. The New York City Department guidelines go on to say that motivation improves when patients have a positive experience with and trust in clinicians. Empathy builds trust and is a potent motivator. So for doctors, nurse practitioners, physician's assistants, pharmacists, or clinical aides, the most important thing we can do for our patients is have them know that we are looking out for their benefit, such that we build trust and motivate patients to adhere to their medications and lifestyle. So in treating the whole patient, we talk about improving self-management. And self-management includes not only medication adherence listed on the left, but healthy eating, especially decreasing sodium, which is a problem in the southeast area of the United States, middle-aged and older patients, patients with obesity, chronic kidney disease, and perhaps more potent in African Americans as a risk. Exercise, or should I say physical activity, because it does not necessarily mean going to a gym. It could be walking, cycling, doing yard activity, or even brisk housework, 20 to 30 minutes most days of the week, may assist with general well-being and blood pressure control. Smoking cessation, of course, there's no need for anyone to smoke. Stress reduction, medication adherence, which I mentioned earlier, and recording the blood pressure, making sure that the blood pressures that are given by the patient at home blood pressure monitoring are accurate. And we'll discuss home blood pressure monitoring in another minute or so. Some of the barriers that we need to address include education, access, money, and motivation. So it's not enough to simply call in a prescription for a new medication to a patient. We have to look at self-management, lifestyle, stress, smoking, and medication adherence in order to have positive blood pressure control. So what should you do when treating the whole patient to improve adherence? Well, my simple prescription is that you talk to your patient. This usually means sitting down in a chair or on a stool at eye level using culturally appropriate, educationally appropriate language, not the technical jargon that we often speak among ourselves. And having the patient teach back, having the patient tell me why you were prescribed this medication, do you understand? Making sure that the patient can afford the prescription. If they have a formulary, that the medication is available. Ask the patient, do they think this medicine will help you? Some of them will tell you honestly no, and that they don't like taking medicines. This is then an opportunity to explain how important it is to control blood pressure in terms of cardiovascular events and overall mortality, as we saw in the SPRINT trial and other large trials. Patients are often concerned about the side effects of medication, and the visit in the clinic is an opportunity to allow the patient to tell you about problems that they may be having with the medicines or perceived side effects, which may not even be related to the medication at all. Especially for older persons, with their agreement, we could find a family member or friend who can help them remember to take their medicine or use tools such as medication boxes to adhere to their medication profile. In treating the whole patient, however, it's more than medication. As I mentioned before, therapeutic lifestyle changes, meaning things that a person can do that helps their cardiovascular risk, remain important. However, especially in disadvantaged and some minority areas, patients don't feel safe. So ask the patient, is there an area where you can walk around your neighborhood? Or perhaps there's a church or a local gym or senior center where you can go to exercise on a regular basis. And ask the patient to describe their activity level to get some assessment of how fit they may be. Remember, in high-risk, middle-aged and older patients, however, if there are any symptoms or any signs that suggest underlying cardiovascular disease, they may want to consider a stress test before embarking on a more vigorous activity level. Food deserts means a lack of available fresh fruits or healthy foods within certain communities. And make sure when you make the recommendation, for instance, to adhere to a DASH-like diet, high in fruits and vegetables, low-fat meats, and low-fat dairy, that these foods are available. In some areas, the corner store is primarily soft drinks, alcohol, and snacks. Finally, if the patient has the inclination or time to prepare and eat fresh meals, and have them understand what high sodium content is. This is especially found in certain baked goods and canned foods. More than just removing the salt shaker, however, because 77 to 78% of the sodium in the diet is already in the prepared foods. Removing the salt shaker from the table, which we often will suggest, does much less than eating foods which are not prepared high in sodium. The family environment is also important. It's going to be very difficult if the person has a family that doesn't support their changes in therapeutic lifestyle. Losing weight is perhaps even the most difficult task beyond diet changes, and see if there are friends and family who can support the patient with effort of maintaining healthy weight. Here's some specific recommendations. This is directly from the New York City Health and Hospitals Corporation guidelines, but much of this was also seen in some of the NHLBI papers that have been published in the past. For physical activity at the top, remember we're using the term activity to avoid the idea that you need to go to the gym to exercise. At least 2.5 hours of moderate activity, brisk walk, that would also include cycling or doing gardening or housework a week. There are data that physical activity actually can lower systolic blood pressure anywhere from 4 to 9 millimeters of mercury. The DASH diet, which I mentioned earlier, is described in the middle of this slide. It's based on eating plenty of fruits and vegetables, low-fat dairy products, whole grains, fish, lean poultry, and nuts, a diet which then is low in saturated trans fats and total fats. The DASH has actually been shown in at least one clinical trial to lower the systolic blood pressure from 8 to 14 millimeters of mercury. And it should be noted that the DASH diet was actually more effective in African Americans. Reducing sodium is important, although you'll hear debates as to whether or not salt in the food has any impact on blood pressure. Specifically for older persons, African Americans, patients with chronic kidney disease, and patients in the South, there is an increase in sodium intake and a reduction of sodium intake to at least 2.4 grams a day has been shown in those populations, especially to lower blood pressure. Intake in potassium is important also, but be careful in patients who have chronic kidney disease with potassium supplementation. The third box is weight reduction. Note how difficult it is for patients to lose weight, and small steps are important. Alcohol consumption. Some patients may have heard that alcohol is, quote, good for the heart because it raises the HDL. But the rest of the story is for a woman drinking more than one drink a day, or a small person, or for most men drinking 2 or more drinks a day, actually can have an effect on increasing blood pressure. So query the person on their alcohol consumption and suggest they make adjustments as needed to curtail excessive alcohol intake, since this may have some effect on their blood pressure. Oftentimes, the effects of the alcohol is hidden because the patient has not told their clinician or provider about these problems. On the right-hand side, you see various culturally competent, literacy competent materials that you can get from the government, free resources in the public domain, meaning that they can be downloaded and printed. At the bottom of the slide, I have a website, www.omhrc.gov. That's the Office of Minority Health that has these pamphlets available. You also can get these pamphlets from the NHLBI site, National Heart, Lung, and Blood Institute. Why is this important? Well, especially in racial and ethnic populations, there's real disparities in terms of blood pressure prevalence and control. And furthermore, almost half of patients, 48% of patients who have hypertension or diabetes, have inadequate health literacy, meaning that they have less knowledge about their disease, the important lifestyle modifications that we just discussed, and the essential self-management tools. Also note that these free resources are often done in multicultural and multilingual patterns such that the patient can feel more comfortable reading or utilizing the materials. Home blood pressure was measuring blood pressures by oneself outside of the doctor's office. And this is a strategy, the first bullet, that has been shown to improve blood pressure control when supported by clinical staff. This is also known as home monitoring. A call to action was issued in 2008 by the American Heart Association, American Society of Hypertension, and the Preventive Cardiac Nurses Association, suggesting that home blood pressure monitoring be considered an essential part of blood pressure control. One problem is to ensure that the patient has a validated blood pressure cuff and brings the monitor in to compare it to what's done in the clinic. But home blood pressure monitoring engages the patient and lets them understand the importance of controlling blood pressure throughout the 24-hour cycle. In terms of the benefits of doing home blood pressure monitoring or self-blood pressure monitoring, the Community Preventive Services Task Force recommends this, and they note that there are data that patients who do self-monitoring of their blood pressure actually have a decrease in the systolic blood pressure, an average of 3.2 millimeters of mercury, and a decrease in diastolic blood pressure, an average of 1.3 millimeters of mercury. When these interventions are also supported by additional measures including team support, the decrease in systolic blood pressure may be as much as 4.6 and diastolic 2.3. The resource is listed at the bottom of the slide, thecommunityguide.org. Let's revisit team-based care. Team-based care is now being considered important for the control of several chronic diseases, not only hypertension but also diabetes. It includes not just the patient, or we, the primary care provider, but also nurses, pharmacists, dietitians, social workers, and community health workers. Community health workers are laypersons who may not have any degree at all, but have been educated about cardiovascular risk, how to take blood pressure, and give basic information to patients so that they can better understand their chronic disease and become partners in their care. At the bottom of the slide is listed the Million Hearts program. One word, millionhearts.hhs.gov. I will not go into more detail, but you should know that this particular program is an overarching program of the government that is attempting to reduce by 2017 the number of heart attacks and strokes in the United States by 1 million. The Community Preventive Task Force reviewed 77 studies on team-based care and found that when you have a team working together with the patient, blood pressure control is improved rather than just having a single physician. It increased the proportion of persons who had their blood pressures controlled, decreased systolic and diastolic blood pressure, and also had a benefit on diabetes and blood lipids, since these patients often have multiple chronic conditions. Again, more information on team-based care can be found at the millionhearts.hhs.gov site. The primary care provider can also help in terms of using the team for medication management and follow-up, helping patients with adherence, following up on monitoring the blood pressure both in the clinic and at home, taking medications, reducing sodium, and increasing physical activity. This is a sheet, and something like this can be duplicated in any particular clinic that helps the patient be a partner in care. It's almost like a form of a simple contract. You have goals that the patient is going to attempt to adhere to in terms across the top, eating certain servings of fruits and vegetables a day, walking certain minutes, taking their medications, understanding and have a list of medicines, limiting salt. Unfortunately, it shows the salt shaker, but I've already mentioned that 77 to 78% of sodium is in prepared foods. Stopping or limiting alcohol. We can't make alcohol as a public health recommendation because higher levels of alcohol intake are increasing with the blood pressure and may actually increase the risk of certain cancers, homicide, suicide, motor vehicle accidents, etc. Stopping smoking, of course, and any other goal that the patient may want to do as a partner in his or her care. In the middle of this sheet, there are some basic simple questions on how you're going to approach these goals one at a time. What to do, when to do it, where to do it, how often, and how you're going to get there. And then have the patient grades similar to what you see in shopping when purchasing and you get a recommendation to give an assessment of the experience. Have them give an assessment of how important these goals are to them and how sure they are that they can reach these goals. At the bottom, the patient signs and the clinician signs, giving somewhat of a non-binding contract to increasing lifestyle modification and adherence to medication. Let me give some take-home messages, and hopefully you have questions. I'm purposely going to stop in a few minutes so that we can discuss some of the points that have been made in this particular presentation. Here are the take-home messages. First of all, age is a powerful risk factor for isolated systolic hypertension and complications, especially in high-risk groups. If you remember the SPRINT trial, it enrolled patients who were 50 years and older who had additional risk. Treating those patients robustly gave a significant reduction in cardiovascular events and overall death. The second bullet. Although the JNC8 recommends at this point 150 as the initiation and less than 150 as the goal in persons who are 60 years and older, in general, it is recommended that less than 140/90 is the goal that has been shown to have dramatic reductions in hypertension complications with blood pressure reduction. And also remember that the medications that are used in most studies are often in combination, regardless of the initial therapy. Take-home message, the JNC8 guideline, which again was not actually validated by the National Heart Blood Institute, is somewhat controversial in the recommendation of 150 as the goal, less than 150 in persons who are 60 years and above. And of all the various guidelines in the world, it's the only one that recommends looser blood pressure control as young as 60 years of age. It should be noted in patients who are very elderly, 80 years and above, perhaps the 150 is appropriate in that particular population. The final bullet, controlling blood pressure is one of the best things that you can do in terms of helping the patients live longer and live a more healthy and productive life. Efforts to control blood pressure, particularly in blacks, older women, and high-risk patients who have coronary disease, diabetes, chronic kidney disease, or secondary stroke, still should focus on treating the blood pressure to less than 140/90. The blood pressure goal for diabetes and hypertension is now 140/90, but the latest iteration of the ADA treatment recommendations does note that for younger patients or in patients who are at high risk, for instance those with a risk for recurrent stroke, if acceptable and can be done with tolerance and ease, less than 180 may be an acceptable target. We showed data suggesting that ACE inhibitors and ARBs may be less responsive as initial therapy. But it also should be noted, in the interest of time, we did not show data such as the AST trial, where having an ACE inhibitor in patients who already have chronic kidney disease is still appropriate. Remember that multiple drug regimens, especially in higher risk patients, will be needed. We specifically called out chlorothalidone as an effective thiazide type diuretic. We mentioned the RAS blocking agents, renin-angiotensin system agents, such as the ACE inhibitors and the ARBs, with a mention of angioedema, the addition of calcium channel blockers, and I did not detail, but most hyperspecialists now accept the addition of low-dose spironolactone in the more resistant or difficult to treat patients. In our take-home message, we went back to therapeutic lifestyle as the bedrock of appropriate care, in addition to pharmacotherapy, and highlighted the importance of home blood pressure monitoring as an additional measure and team-based care to lead to optimal outcomes in blood pressure control. Thank you very much. There is an email address here if you need to get more information after this presentation, but we do have a few minutes and hopefully there are some questions or dialogue that can take place. I appreciate the time of those of you who have taken out the time to participate in this webinar.
Thank you, Dr. Ferdinand. It's now time for questions. I do want to thank Dr. Ferdinand also because he has been such a supporter of the FQHCs in our educational sessions. Dr. Ferdinand, we do have a question. When do you expect, or do you expect, JNC 8 panel to make changes based on the SPRINT data?
That's an excellent question. Let me refine to you the concept of the JNC committees. I was one of the chairs of JNC 6. And JNC stands for Joint National Committee. What is the Joint National Committee? It's a group that's a committee of the National High Blood Pressure Education Program of the National Heart, Lung, and Blood Institute. However, the National Heart, Lung, and Blood Institute, or NHLBI, no longer has those panels. So the paper that came out in JAMA, which we, for shorthand, use JNC8, was really not part of the JNC8 series because it was not blessed by the NHLBI and did not come out of the same process. Therefore, there will be no JNC9 because the NHLBI has disbanded the National High Blood Pressure Education Program. However, to answer your question more directly, there will be a guideline that comes from the American College of Cardiology and American Heart Association, perhaps towards later in 2016 and 2017. And I fully suggest that they're going to digest the SPRINT trial and suggest that we reverse this idea that a goal of less than 150 is adequate in persons who are 60 years and above. Remember, the SPRINT had persons who were 50 and above, and even in that subgroup of patients who were 75 years and older, there appeared to be an improvement in cardiovascular outcomes and mortality with more robust blood pressure control.
Thank you. The next question, when you begin a clinical practice guideline for blood pressure management, sometimes modifications have to be made within that guideline. What's your recommendation on when it would be best to consider a different guideline?
When we have landmark trials that have hard outcomes, I think it's time to reconsider our recommendations. So for instance, the JNC8 panel, again not blessed by NHLBI, came to the conclusion that we did not have enough data that getting the blood pressure less than 150 in persons who are 60 years and older actually gave outcomes benefit. Now we have that data, and it's time now to reassess our approach to those patients. The ACCHA guidelines will give you a particular guideline recommendations, but I think the prudent clinician will treat patients intensively and robustly while taking time to avoid orthostatic hypotension, where the person gets weak or dizzy when they stand. And again, if you remember our partnering with the patient slides, asking patients about side effects and whether or not they think the medication is helping them. Because if the patient has undue side effects or they believe that it's too much medication, then they're not going to adhere. And in fact, the blood pressure will not be treated intensively. It may not be treated at all.
Good advice. Thank you. In a younger patient, what factors besides stroke risk should you consider in deciding whether or not to treat to less than 130/80 in the younger
Well,
patient?
if you remember, most blood pressure studies are done in older persons. And one of the reasons is that with a younger person, over the 3 to 4 years of most clinical trials, you're not going to have enough heart attacks, strokes, or death to show benefit. So in general, trials try to enroll older persons. But let's be reasonable. The lifetime risk of a person who is in their 20s or 30s and they have obesity, type 2 diabetes, and elevated blood pressure is great. Although you can't say based on a clinical outcomes guideline that if you treat them for 1 to 2 years with drug X or drug Y, you're going to decrease strokes or heart attacks, it is reasonable to try to reproduce what you see in the observation, and that is, in younger people, if the blood pressure is over 130/80, clearly for their age, that's too high. Remember, many young women have normal blood pressures of 90 or 100 or 110. So a young woman who is relatively thin, doing well in high school, perhaps participated in gymnastics or did tennis and did dancing or aerobics, and now has had 1 or 2 children, gained weight, still is very young, 29, 30 years of age, but has a blood pressure of 132/80. For that person, that's a 20 millimeter increase in blood pressure. I think it would be unreasonable to say, because we don't have a specific trial in a 30-year-old woman showing benefit, that we would not treat that patient more robustly.
Thank you. As a cardiologist, what are your recommendations for when a patient with hypertension seen in a primary care setting should be sent to a cardiologist?
Referral to the specialist is especially needed if the patient is on 4 or more drugs and you're not getting the patient to goal. And specifically as it relates to the cardiologist, if the patient is giving any symptoms at all, I would send them for referral. Remember, the chest pain, left anterior chest, radiating into the neck or the arm, lasting 5 to 10 minutes, relieved with rested nitroglycerin, classic angina, is only found in about 20% of patients who have severe coronary disease. And in fact, especially for women, many women have heart attacks and never have pain. So we are now talking about treating risk and not just treating symptoms. Clearly, if a person is high risk, has high cholesterol, diabetes, and a blood pressure which is difficult to control, I would suggest referring them to a specialist for further evaluation. Those patients may have something underneath the blood pressure itself that needs to be evaluated.
Good advice. I think that's all the questions that we have. We can give a few seconds while I'm giving closing comments to see if there will be any more. I do want to again take a moment to thank Dr. Ferdinand for conducting the presentation today. We will post the recordings of the learning session on the LPCA website. And if there are no further questions, this concludes our hypertension management webinar. Thank you for participating and have a great day.
Thank you.
Ferdinand.
All righty.